This topic is about nausea and vomiting in pregnancy. In pregnancy, we want to check if the patient has hyperemesis gravidarum or not. So, signs that can help us in diagnosis is if the patient has ongoing weight loss more than 5%, or ongoing requirement for intravenous fluid and emergency department admissions, and no response to standard therapies. In history taking, we check the fluid intake, food intake, weight loss, and urine output and vomiting. We check if the nausea and vomiting are occurring at the expected date. We usually expect it to start at 4th to 7th week of pregnancy and peak at 9th week. It usually settles by 12 to 16 weeks. We check to see if the patient has tried any medication in this pregnancy or previous pregnancies. We also check that if the patient has done any ultrasound. In history, we check if the patient has had any problems before pregnancy, like reflux esophagitis, peptic ulcer disease. Any smoking status is also important for us. It's very important that we ask about domestic violence issues. In medical history, we also check if the patient has taken any medication or has allergy to any kind of medication. We check to rule out other causes of nausea and vomiting, such as if the patient has any intercurrent infection like UTI, gastroenteritis, gallstones, or diabetes. Thyroid dysfunction is also important for us. The physical examination starting by general appearance of the patient, if the patient is ill or drowsy. Then we go to the vital sign. All of the vital sign is important here. We check the blood pressure for orthostatic hypotension. We check the temperature for fever, and we check pulse rate for increase rate. Then we check mucous membrane of the patient, skin turgor, and peripheral circulation. For sign of dehydration, we check the patient's weight for any decreased weight and hyperemesis gravidarum. If we have any positive finding, it's important to check neurological examination. Any sign of increased ICP, we check the fundoscopy. If we have any sign for thyroid condition, we examine thyroid as well. And we examine abdominal, we check abdominal examination for any tenderness, any mass, and rule out any causes other than pregnancy. In office test, we check urine dipstick for ketones and urinary tract infections. We check the blood glucose level as well. For management, in non-pharmacological management, we can advise the patient to have small amount of fluid frequently, like flat lemonade, sport drink, and diluted fruit juice can help. We can also ask the patient to have small, frequent, high carbohydrate and low fat meals when nausea is at its lowest level. Small snacks of bland and salty carbohydrate-based foods are easier to tolerate. Ginger can help some patients, so we can tell them to have raw ginger roots or tea or sweet or ginger ale, and some capsule is also available. Vitamin 6, B6 can help some people as well. We can have the patient to take them 3 to 4 times a day. And wrist acupressure has also been mentioned in the text. In pharmacological management, if the patient has reflux, we can advise them to take rabeprazole. And if no reflux, the first medical treatment that we prescribe patient is doxylamine, which is the pregnancy category A. Then if the symptom does not respond, we add metoclopramide and then prochlorperazine, and then the last resort is ondansetron.